Welcome to Derm Drop, your TLDR in dermatology. I'm David Sider, your host, bringing you quick picks from the dermatology literature and other sources in the dermatology community that are interesting and impactful. Episode 7 begins with an all too familiar scenario. Next time you have a patient that is nervous about starting a biologic and needs just a little extra nudge, go ahead and tell them that it might protect their brain as well as clear their skin. Researchers from Israel published a study in the May 13th, 2025 issue of the Swedish journal Acta-DV, suggesting that psoriasis biologics may be neuroprotective. The retrospective cohort study assessed rates of dementia diagnoses in 1,766 psoriasis patients aged 65 and older at least 12 months after biologic initiation. Patients who were on TNF-alpha, IL-17, and IL-23 inhibitors had a 53% reduced dementia risk compared to those on oral systemic therapies such as apremilast, methotrexate, acitretin, cyclosporine, etc. And that was after adjusting for age and other confounders. It's hard when a patient is resistant to a therapy that you believe will change their life for the better, but nobody likes the idea of being put in memory care. So when they dig in their heels, you could add that a biologic might also prevent dementia. Not to be manipulative, but to ensure that they have all the facts they deserve to make informed decisions about their health and long-term well-being. Our next item is about another familiar situation, hopefully not as familiar as the last one, but this one is when you have a very tough recalcitrant HS patient and they get pregnant and they plan to breastfeed. Most hidradenitis suppurativa patients experience disease activity while pregnant, with 20% worsening during pregnancy and 60% worsening in the postpartum period. Pregnancy is hard enough. You don't want to add a 9+ month HS exacerbation to it because you're not comfortable with safe treatment selection. And HS increases risks of adverse fetal and maternal outcomes, including spontaneous abortion, congenital anomalies, gestational diabetes, preeclampsia, and cesarean sections. Treatment may reduce those risks, and it certainly reduces suffering. Wouldn't it be nice to have a one-stop shop for evidence regarding what therapeutic options are okay and which ones are a no-go? Well, researchers published exactly that in the March 25th, 2025 issue of the American Journal of Clinical Dermatology. And here's the Derm Drop condensed version. Topicals that are okay include benzoyl peroxide, chlorhexidine, and topical clindamycin. You want to avoid resorcinol, ruxolitinib, and clascoterone, although you may use clascoterone with caution in lactation. Oral antibiotics that are okay include clindamycin, ceftonir, cephalexin, but that may cause diarrhea in breastfed infants, amoxicillin clavulanate, at least after the first trimester, and metronidazole, although you should avoid breastfeeding for at least 12 hours after. Oral antibiotics that should be used with caution include rifampin, which is actually okay in lactation, ertapenem, and dapsone, although breastfed infants should be monitored for hemolysis and jaundice. Oral antibiotics that you want to avoid include tetracyclines, fluoroquinolones, and trimethoprim sulfamethoxazole. Metabolic therapies, metformin's okay, GLP-1 agonists are not, although you may use GLP-1 agonists with caution in lactation. Of course, you should avoid oral retinoids. Hopefully, that's a no-brainer. You should also avoid hormonal therapies, also hopefully a no-brainer, although spironolactone is okay while breastfeeding, but may suppress lactation. Oral contraceptives have the potential to suppress lactation and cause infant breast enlargement, but otherwise might be okay in lactation. Biologics that are okay to use, of course, certolizumab, which has been studied and is known to not pass through the placenta to the fetus. Biologics which you can use with caution include adalimumab, that's actually okay in lactation, Infliximab, also okay in lactation. Secukinumab has a lack of lactation data, but minimal transfer is expected. Bimekizumab is also okay in pregnancy and also has a lack of lactation data, but minimal transfer expected. Ustekinumab is okay in pregnancy, and the limited lactation data that we have showed no significant differences in neonatal infections or milestones. The biologic that you want to avoid is anakinra, although you may use that with caution in lactation. You want to avoid small molecules, including apremilast and upadacitinib. Traditional immunosuppressants that you want to use with caution are systemic corticosteroids, although you can use it in lactation, though you have to wait 4 hours after to breastfeed, and lactation may be suppressed by high doses. Cyclosporine should also be used with caution during pregnancy and lactation. Procedures that are okay include intralesional corticosteroids, although large doses may suppress lactation. IND and deroofing, although you should avoid epinephrine and povidone iodine in lactation. To use with caution are cryoinsufflation and excision due to positioning risks and fetal exposure to general anesthesia. And you want to avoid botulinum toxin and laser. Lack of lactation data in laser use, but the risk is low. Supplements such as zinc are okay in pregnancy and lactation. The thing you want to remember here is that healthy mothers make healthy babies. So take the risk-benefit ratio and discuss that with your patient and make decisions on a case-by-case basis. Our next item is about dark spots. Nobody likes them, but everybody in the skincare and cosmeceutical space claims to treat them. The most recent entrant, Thiamidol, Eucerin's patented tyrosinase inhibitor, has been getting the TikTok love of late, but what does the science say? Some big-name scientists, including Seemal Desai, Hilary Baldwin, Pearl Grimes, and Sherry Frey, among others, presented a poster at the 2025 Winter Clinical in Hawaii that showed that isobutylamido thiazolil resorcin's IC50 is 1.1 mu moles per liter compared to hydroquinone's IC50, which is over 4,000 mu moles per liter. In English, what does that mean? Well, the IC50, or half maximal inhibitory concentration, is the concentration needed to reduce a biological process by half. So less is more. And thiamidol's IC50 is much lower than hydroquinone's, meaning it's a lot stronger. Except it does not have the exogenous ochronosis or irritation of the hydroquinone retinoid combos that we're used to using, as thiamidol is generally well tolerated. So the hype checks out, and yes, it works on solar lentiginase and post-inflammatory hyperpigmentation in addition to melasma. Our last item of episode 7 is about lichen planus and whether you still screen for hepatitis C. Well, 91% of dermatology practitioners do, according to a survey conducted by Adam Friedman et al. Of the Department of Dermatology at the George Washington University School of Medicine and Health Sciences in Washington, D.C., published in the April 24, 2025 issue of Dermatology and Therapy. But the authors point out that Hep C only occurs in 0.64% of lichen planus cases. So, unless the patient has risk factors, we can all go ahead and stop that practice and start screening for cancer. While hypertension and hypercholesterolemia are more commonly associated with lichen planus, those rates are in line with background population rates. Malignancy, on the other hand, affects over 19% of patients suffering with lichen planus. That's almost 1 in 5. Compare that to the 1 to 2% of U.S. adults being treated for or recently diagnosed with cancer. It's a big difference. And even if you include those with a history of cancer, the population rate bumps up to less than 7%, which is still well below the 19 plus percentage rate in lichen planus. Thyroiditis and rheumatic disease rates are also higher among those with lichen planus, but the discrepancy is not as striking as it is in malignancy. Other associations, including metabolic disorders, type 2 diabetes, and depression, were in line with or within a few percentage points of baseline rates. Proposed etiologies of lichen planus include dysregulated immunity, genetic predisposition, medications, infections, and psychological stressors. But lichen planus can also be a paraneoplastic phenomenon, as tumors may provoke an immune response that cross-reacts with skin or mucosal antigens. So complete a thorough review of systems and ensure age-appropriate screenings are up to date, because lichen planus just may be the canary in the proverbial coal mine. And that wraps up episode 7. If you are interested in checking out the articles, you can click the link below to go to my LinkedIn, where all of these articles are linked to the original content. And please, if you liked what you heard, hit the thumbs up button, subscribe, and stay tuned for more episodes. Thank you. Is a combination of the two. Either way, CHE is legit, not just a subset. Starbucks, which involves wet work, Amazon, which involves handling boxes in dusty warehouses, and nail salons for both techs and patrons alike, are producing ever more eczematous hands, and all it takes is 2 episodes per year or one lasting 3 months to be considered chronic. Are you ready? Path matters. Thanks to Omar Noor for the helpful breakdown published April 23, 2025 in Dermatology Times. Next is for those of you that have a patient with a face full of flat warts. We've all had one of these. Topical and procedural treatments like salicylic acid preparations and liquid nitrogen are irritating, ugly during the treatment period, potentially disfiguring in the post-therapeutic period, and can even cause the warts to proliferate and spread, especially in shaved areas because they disrupt the skin barrier. So what can you do? You can treat orally with isotretinoin. In this case, the magic formula appears to be 0.5 milligrams per kilogram per day for 12 weeks. At least that's what researchers in Mexico City found when they compared that dose to 0.3 milligrams per kilogram per day in a double-blind, randomized study published 21 April 2025 in Health Science Reports. It turns out isotretinoin's efficacy in this population has been previously published, and this study was more about optimal dose finding than proof of concept. But if you're like me, you've had patients with numerous facial flat warts and struggled to walk the tightrope between efficacy and unwanted iatrogenetic effects of our typical treatment modalities. Of the 19 patients in the higher dose group, almost 74% achieved complete response, and the remaining 26% got a partial response. That's not a shabby response rate, and these were really tough patients. Inclusion criteria were prior treatment for at least 3 years with at least 2 of the following: topical retinoids, imiquimod, 5-fluorouracil, and or cryotherapy. So let that sink in. Accutane did in 3 months what multiple other therapies couldn't do in 3 years. Sure, the subjects experienced some cheilitis, but that's easily manageable and better than blisters and open sores on your face, right? Thanks to the authors for providing open access to their findings. Next, do you have an itchy old gal who swears she hasn't changed her laundry detergent? Ask her if she's started a blood pressure medication in the last 2.5 years. As the population skews older and a variety of eczematous conditions become more prevalent in mature skin, the itchy elder has become an increasingly common occurrence on derm schedules. But it's not just senescent cutaneous changes resulting in barrier dysfunction and xerosis that are to blame. Several studies over the years have shown that antihypertensives are frequently the culprits in new or ongoing eczematous eruptions in older patients. These rashes may be localized, especially on the lower limbs, or generalized. And the medication does not have to be new. In one study, the latency period for onset ranged from 4 to 30 months. So, which blood pressure meds should we look out for? Well, maybe all of them, as the hazard ratio of eczematous dermatosis in patients receiving any hypertensive was 1.29. But alas, correlation still isn't causation. So, calcium channel blockers, especially amlodipine in stasis dermatitis, and thiazide diuretics, especially hydrochlorothiazide, aka HCTZ, appear to be the worst offenders with odds ratios of 4.21 and 2.07, respectively. Smaller effect sizes are seen with angiotensin converting enzyme or ACE inhibitors, angiotensin 2 receptor blockers or ARBs, and beta blockers. And don't forget to look for stealthy combination drugs with increased risks, as lisinopril/HCTZ is a common combo. If you biopsy, spongiosis with or without associated psoriasiform changes and or interface dermatitis are consistent with this type of drug reaction. Working with the patient's primary care provider or cardiologist to change medications can be cumbersome, but in many cases, the reaction is dose dependent in lowering the strength of the offending agent with or without a coordinated increase in another may be enough to clear the rash while maintaining optimal pressures and avoiding exacerbation of polypharmacy and the potential adverse effects that come with symptomatic treatment with a topical steroid. Thanks to Warren Heyman and Katrina Abubara, whose survey of relevant literature on the topic for the American Academy of Dermatology Reading Room Selection published 14th of April 2025 on the MedPage Today, which served as a reminder of the importance of the medication list for dermatology detectives. Finally, does your alopecia areata patient want their hair back yesterday? Well, tell them to take their JAK inhibitor at bedtime. A study published April 17th, 2025 in BMC found that Eli Lilly and Company's JAK inhibitor, baricitinib, marketed under the brand name Olumiant, achieved higher ACR20 scores in rheumatoid arthritis patients when administered in the evening. The difference was especially striking among those taking the higher 4 milligram dose, with over 78% in the evening arm meeting the endpoint at week 12 compared to over 43% in the morning arm. So, why would dose timing make a difference? Well, because cytokines have circadian rhythms too. And TNF alpha and IL 1, the predominant cytokines in rheumatoid arthritis, are nocturnal. So, what does that have to do with alopecia areata? Well, the primary cytokine in alopecia areata is interferon gamma, which is also a night owl. And interferon gamma signals through the JAK-STAT pathway, particularly JAK1 and JAK2, which baricitinib blocks. Of course, we need randomized controlled prospective trials to replicate the RA findings in the AA population, but evening dosing is a free and easy intervention with a plausible mechanism for superior efficacy. And with similar adverse event rates among groups in the RA study, there appears to be no additional risk or downside to evening dosing. So why not make it standard practice when prescribing baricitinib? And ritlecitinib, or Litfulo for that matter. And while we're at it, IL-13, the key cytokine in atopic dermatitis, is generally more active at night as well. So you might as well consider evening dosing for upadacitinib, or Rinvoq, and abrocitinib, or Sabinco too. Interferon gamma is also the primary driver of vitiligo. So when JAKs get that indication, you already know what to do. Night dose. And if heightened nocturnal cytokine activity weren't enough, mast cells have a lower threshold of activation at night. So when your patient says their itch is worse at night, it's not just because they don't have daytime distractions to take their mind off of it. It's actually more severe at night. Thanks to the authors for giving us this Jack hack. And that wraps up our episode 6 of the latest Derm drop. Thanks for tuning in. And if you are interested in the articles, go ahead and hit that button to connect over to my LinkedIn, where these posts can be found with links to the original articles. Also, hit that share button, hit the thumbs up button, and tune in 2 weeks for the next episode. Thank you.